I mean, I think this whole discussion about biomarkers really comes down to this ever-evolving and growing important field of personalized medicine, precision medicine, I believe is what Eric Klein talks about. And so if you think about what we do, we have these long discussions with patients about prostate cancer, and we tell them about survival statistics, and we tell them about if you have this, the chances of you have nodal disease versus extracapsular disease. And if you think about this, we're making some really basic assumptions. I mean, this is all population-based data. So we're making the assumption that number one, every tumor acts the same way, and number two, everyone's immune system acts the same way, and it's really not that way. So how do we get this more personalized? You know, we know that all Gleason 3+3s, 3+4s don't behave the same way, and it really comes down to the patient's own individual tumor. So again, in terms of the big one, which I think is right now, is this: who needs to be on active surveillance? Who is going to progress? Who does need definitive therapy? Who can we sit back and comfortably? We may not be able to totally not treat them, but it could be a delay in therapy, depending upon, again, other markers. So Oncotype DX, the GPS score, you know, they've been involved in the breast cancer world, I believe. So now they've got the GPS, you know, which is their genomic prostate score. So, Dr. Cheatham, what are your thoughts? Have you used it yet? You know, what are you doing with it?
So we're using this in our practice. We know that if you take 100 men with Gleason 6 prostate cancer, as you say, they're not all going to behave the same. And in that 100 patient population, there will be some Gleason 6s that behave much more aggressively than we would expect, and some that will behave less aggressive. I think the role for the Oncotype DX is to try and tell us, is this a good patient to stay on active surveillance or not? I'm a strong believer in active surveillance, but I'm also looking for reasons to take patients off active surveillance if I feel that it's not safe for them to remain on an active surveillance program. I think the nice thing about the Oncotype DX is that if you have a patient whose biopsy shows Gleason 6 prostate cancer and they have a very, very favorable score, then that's encouraging for the patients to know that. And those are the patients that, in conjunction with a negative MRI with no evidence of capsular involvement, then I would be encouraged to see a favorable score. I think for patients who have a Gleason 6 on biopsy with a negative MRI, PSA stable, but their score is very high, then that makes you sit up and think, does this patient have more aggressive disease based on these 17 gene markers in the Oncotype DX test? I think it's important for patients to know that this is only a test that can be done on biopsy material that's within 6 months of the biopsy. So if they had a biopsy 8 months ago, then you cannot do this test on tissue outside the 6-month window.
Mike?
And as of right now, at least per the company, you can't use this as part of a surveillance strategy. So we don't know, honestly, it should be stable. We would all think that as a genomic marker, it would be stable. We don't know if the biopsy that we take in an active surveillance or when they first start and has a small volume of Gleason 6 cancer and that has a low score, does that translate to the next biopsy 2 years down the road as a low score as well? So that part of it, I think, needs to still be clarified. But it does at least give you a little bit more sense of relief that this is a person that's going on. In a day and age where average across the board prostate cancer, still we're all touting active surveillance and this is what we want. But if you look at most practices, this is like 10%, if they're lucky, 10 to 15% of their prostate cancers are being treated with active surveillance. That's just a message that could help alleviate some of that, sense of heartburn again.
And just based on anecdotal evidence, I've certainly noticed that the patients in my practice who tend to have a higher score do tend to be the African American men that tend to have more aggressive disease. And when I see an African American gentleman with a Gleason 6 prostate cancer, it's not uncommon to see a higher genomic score than you'd be expecting.
I mean, Ken, wouldn't you agree this is all about better risk stratification?
Absolutely. Right? And I think it's almost, Neil and I were talking before we started about how, years ago this whole advanced prostate cancer thing was a revelation. And I think we're there now with this. I mean, I think, in a lot of our practices, we're trying to increase that patient population that can go on active surveillance, and I think this will be the role for it. But again, I think nationally still, we're still way behind, and I think hopefully, this test and the other one, like the Polaris, will help, obviously, stratify those patients who can, go on active surveillance successfully.
So Neil, walk us through a case. I mean, because I know you've used a ton of these. Walk us through a case how typically a patient who you would go ahead and send off for the GPS.
Sure. So like you said earlier, there's all this heterogeneity, and so patients will sometimes come in and tell me, if you've not heard this comment, you get a patient could be in good health and you diagnose them with prostate cancer, and their first comment without knowing any information is, well, no one dies of prostate cancer. I read that in the Wall Street Journal. I don't even know why you biopsied me in the first place. And then there are some folks who might come in and say, I've got prostate cancer, I want my prostate out yesterday. So clearly, neither one of those mentalities is really looking at most of the information. We historically have the metrics of the digital rectal exam, the PSA, and the histopathology. The beauty of getting the Oncotype DX is now you have the patient-specific genomic analysis of his tissue from the paraffin-impeded block. You don't have to do another biopsy. So what I do for my patients who are appropriate for it, in the validation trials from Cleveland Clinic and UCSF, which, by the way, the paper just was accepted at European Urology. It's online now. Eric Klein's first author, Matt Cooperberg, Pete Carroll's the senior author, so you can read this validation, which was really nicely done. And really what they did was they validated the fact that you could look at these 17 genes, as you say, for patients who are Gleason 6 or 3+3 or 3+4, who are low intermediate, low risk by NCCN classification. Send in that tissue. It's a small amount of tissue. The cool thing with RT-PCR is we're able to take this little tiny 5 millimeter of tissue and essentially expand these genes so that we go from miniaturizing this information, and that's really the wonder. So we get these genes and you get the scores as Philippa says, and if the score comes back very low, it validates that the patient's very low risk by NCCN classification or low risk, or could sometimes upgrade these folks. And the upgrade or the low grading is really basically saying, what's the risk that if you did a radical prostatectomy on this patient that they'd have either non-organ confined disease or dominant Gleason 4. So what I do, Raul, to answer your question is, I tell the patient, look, I see what your PSA was. Maybe, I think we'll show a case here, 60-year-old man with a mildly elevated PSA. Maybe he changed over time. I did the biopsy, comes back 1 or 2 out of 12 cores, Gleason 6, and he's historically a low-risk NCCN. And he comes in and his wife is like, you got it, my next-door neighbor had a prostatectomy, get that prostate out. And I'm thinking, okay, well, maybe he's a good candidate for active surveillance.
He's thinking that as well.
Well, he's like, that's right. That's exactly right.
It's the wife that wants the prostate
right,
out, not the guy.
I want my husband alive. He's worried about his sexual and urinary function. And so you send off the tissue. It takes about 10 to 14 days to get it back. It's not a repeat biopsy, and you get the score. In this particular case that you'll see on the monitor, the patient's score, actually, he went from low to very low risk. And now I can look that man right in the eye and say, hey, look, we're not doing watchful waiting. We're going to follow you with probably a confirmatory biopsy within a year and continue to monitor your exam and your PSA. And as you said earlier, it's only about maybe in our retrospective studies that we've looked at, and even some prospective, the Canadian trial, that about 20% will eventually upgrade. So why not be able to spare those other 80% avoidance of surgery or radiation? So that's where I've used it. Now, on the same flip of it as well is sometimes I'll get the patient who says, I'm not going to do anything, and indeed the GPS score comes back higher grade. And that's a fellow that I'll look at and counsel and say, well, I might be more convinced to consider prostatectomy or radiation.
I think also you made a good point about the tissue, that if you have a genomic score on the tissue, it in theory should be representative for what's going on in the prostate. So you can't have this situation where you say, well, it's just based on the biopsy tissue, what about what else is left behind in the prostate? Your genomic score should be your genomic score.
That's right. I mean, the interesting thing about their validation and their particular assay is they started off with over 700 genes and narrowed it down to 17 over many years that's why I think this paper will be fun to read. But additionally, they looked at the genes that were predictive of extracapsular extension as well as going to a dominant 4 or 5, and looking at 4 different pathways: proliferation, stromal response, and a couple of others. And I think it gives it a sort of a breadth of validation that is very appealing.